Afternoon to everybody. It will be not this topic. I will speak completely different tissue. I will speak about chronic kidney disease because we didn't mention chronic kidney disease here. Uh, so I will just remind you that chronic kidney disease is still neglected, but increasing global burden. And there are several questions other than whether decline of kidney function in elderly, which occurs, is really chronic kidney disease, or it is just physiological aging. And then the next question is whether declined kidney function in elderly, which should not be CKD, is associated with high cardiovascular and end-stage kidney disease risk. And then maybe the practical question and the issue, how to estimate GFR and what is the definition of CKD in the elderly. So maybe you didn't realize that CKD is ranked 8 as a global burden in global wide this study published last year in Lancet. So you have to remember this, and this is not CKD, this is kidney dysfunction. This should be also noticed. That means glomerular hyperfiltration is here, and microalbuminuria as well is here, not CKD. That means GFR below 60. The prevalence of CKD is very high, and you can see here data in Croatia. 8% of our population has CKD, defined as GFR below 60, and 17% has any stage of CKD. So very high prevalence, higher than the prevalence of diabetes. So this is also important and neglected. And CKD stage 3B, that means GFR 45, is equal as diabetes with complication, or GFR below 30 is equal to MI. And glomerular hyperfiltration with albuminuria is equal to MI. So CKD is pretty serious disease. And you can see here that awareness is very poor. It's a similar like awareness for dyslipidemia. Very rare of patients who have CKD are aware that they have it. The other important aspect is that CKD prevalence and incidence is increasing. And in fact, CKD is the only NCD which has increasing trend. Ischemic heart disease, stroke, every other NCD has declining trend, and CKD has increasing trend. So it is assumed that in 2040, CKD or kidney dysfunction will be ranked as 5th cause of death. So this is very, very important. So who is at higher risk for CKD? Of course, patients with diabetes and hypertension. The women in Croatia are men more at risk for CKD, some racial minorities, and elderly. So are elderly truly at higher risk for CKD or not? And this should be answered particularly when we know the globally population in the earth is aging. And what happens with GFR? You can see here by aging, GFR either measured or estimated is decreasing as we are aging. There are some differences between men and women, and they are mostly related to our sex hormones. And here you can see data on prevalence of decreased kidney function. That means not chronic kidney disease, but decreased eGFR in US population, a HANES study. And of course, this proportion of patients with decreased kidney function is higher in those with diabetes and hypertension, but you can see that this is also substantial number of normal or healthy, apparently healthy populations where this decline of GFR is observed by aging. You can see here similar data from Croatia, from our study, from adult rural population in Croatia, the same data as we are coming from the States. So here are potential mediators of age-related decline in kidney function. Of course, they are all very familiar for you. Again, here are lipid metabolisms. And look here, hyperfiltration. So hyperfiltration should not be neglected, and we have to treat patients with glomerular hyperfiltration as soon as possible, particularly now when we have drugs that decrease glomerular hyperfiltration, like SGLT2 inhibitor. So here are the characteristics of kidney senescence. And you can see decreased GFR, decreased renal perfusion pressure, increased filtration fraction, glomerulosclerosis, they are normally occurring by aging. So this is not a disease, like menopause. This is not a disease. Gray hair is not a disease. They are markers of aging. So, but this is the question, whether this is a risk factor for end-stage kidney disease and whether this decreased GFR in elderly is associated or causing higher cardiovascular risk. And then, is this a risk factor per se, like GFR decrease caused by obesity, or when it is only associated, for instance, with hypertension or diabetes or dyslipidemia? And then the question is how to differentiate healthy aging from chronic kidney disease. And here you can see some markers of healthy aging. I will not go into the details, but they are very well known. But again, in regular clinical work, neglected and overlooked. And we sometimes made diagnosis of CKD in elderly patients who in fact do not have CKD. So some Spanish authors suggested this huge formula, but this formula is not yet validated. And then how to estimate GFR in elderly? Non-equation is validated. So CKD-AP is not validated in elderly, MDRD is not validated in elderly, Cockcroft-Gaul is not validated in elderly, but we have this equation, Berlin Initiative Study, equation which is validated in elderly above 70 years ago and years old, and particularly this BIS2 equation with cystatin C should be used in estimation of GFR in those above 70 years of age. And here you can see here this there is no overlapping between measured and estimated GFR by BIS. And then the next and the last point I will make in this lecture, what is the true definition of CKD in elderly, or when low GFR might be considered normal in elderly? So definitely, universal threshold of 60 milliliters of minute per 173 does not take into account the physiological decline of GFR, which I showed you at the beginning of my talk. And thus, prevalence of CKD could be overestimated in elderly and underestimated in younger. So how can we define normality? There are two methods. One is the classical range values, use second and 90-70 percentiles, or much better the risk-based, which consider the risk outcomes, which is then associated with thresholds. You can see here the classical method, which uses KDIGO universal definition of CKD with eGFR below 60, and you can see a substantial number of men and women above 60 years are in the 2.5 percentile of GFR. So they are not taken into account when we are making diagnosis of CKD. So thus the threshold for chronic kidney disease in the elderly should be below 60. And this is much better. This is mortality risk based age calibrated definition. And you can see here that the risk for cardiovascular incidents starts at different stages of CKD, at different levels of GFR in these younger. It starts already when GFR is 75, and then when we go to the age group of 75 and more, then the risk starts only when GFR is below 45. So this is GFR associated with decreased mortality. In younger than 40 years, it started above this cutoff value of 60, started when GFR is 75. And in those older than 65, it starts only when GFR is below 45. So we need new age-calibrated cutoffs for CKD, and this is the proposal for this new age-calibrated definitions of CKD. So what about the risk for end-stage kidney disease? Interestingly, the risk for end-stage kidney disease is lower in elderly than in younger. So because the elderly are much more prone to die of cardiovascular events than to get the luck to have end-stage kidney disease. So, and the level of GFR for end-stage kidney disease, again, is different for younger and for older. So this is the end of my TikTok, and the second part, which will be about kidney CKD and arterial stiffness, I will give next year. So thank you for your attention.